And we're live.
Welcome, everyone. I'm Fair Sharif, and I'm thrilled to be your moderator for today's START webinar on revisions and conversions. We've got a fantastic session lined up with two outstanding speakers, Dr. Adrian Dan and Dr. Demetrius Stefanidis, who will be sharing the expertise on their complex and evolving topic. Now, if there's one thing we all know about revision and conversion, it is that no two cases are ever the same. And that's what makes today's discussion so important. Just a reminder, the session is all about you guys, so make it interactive. Don't be shy. Make sure you ask questions and let's keep this conversation going. So let's get started. I'll turn it over to our first speaker, Dr. Adrian Dan, to kick things off.
Great, thank you, Faze. Really appreciate it. And I appreciate the opportunity to be here and chat with you guys. I'm going to share my screen here in a second. Can you guys see that? Can somebody give me a thumbs up? Okay. And you guys can see the whole screen, right? It's all the video. Or do you see the background also?
I do see the background.
Okay, let me see how I can make that so it's. How about now?
Now it's better, much better.
Okay,
Yeah.
great. All right. So I like to keep these things fun, and we're going to talk today about conversions and revisions, and Dr. Stefanidis is going to present in a little bit um, some more complicated stuff. But when you talk about conversions and revisions, it's quite a wide array of things that you can discuss. So I decided to talk a little bit about sleeve to SADI, really a conversion of a sleeve to a SADI versus a one-stage procedure. There's not much of a difference, but there are a few tidbits and pearls that we can go over. So feel free to stop me along the way if you guys have any questions. There's anything that we can discuss, and maybe I'll stop along the way in some points and discuss a little bit about the various pearls and techniques that we use. I do want to say that in this first video, you guys always hear at meetings when people say, somebody's stumbling through stuff and people say, well, that's my fellow operating. Well, this is my fellow operating, but I'll say he's slightly better than me. I won't embarrass him too much. And a lot of times people will say it just because they're embarrassed of their own um, mishaps. But in this situation, I'm actually kind of proud to say it's me, but it's actually my fellow. So, of course, we started with the counting, and I wanted to speed this up because this takes forever. It's painful to watch somebody do these cases in live time and regular time. So, again, we count turning the wheel counterclockwise to make sure you don't twist the mesentery of your ilium as you count your 300 centimeters. I wanted to put this in there because I do want to show you guys a nifty little trick that we have here. Once we have figured out the 150 centimeters, I place a silk suture, and it's from the gastrocolic ligament to the portion where I'm going to anastomose to, okay? As long as you don't get into the gastroepiploic, there's really no bleeding. But you see that little loop that I have at the end of the stitch that really keeps things from the suture from going through the tissue right there. So it saves me from having to tie another knot. So this is a little cumbersome when you do laparoscopy through the robotic trocars, as you guys know. But I do like to count laparoscopically because I like to put my ports a little bit higher than is comfortable to be able to count. So I take that through there 2 or 3 times and I actually leave the needle in. I like this portion because the fog just kind of goes away and you can see it's almost like the beginning of a show or something. So I left that in there. It was kind of fun. But this person had a cholecystectomy before, and of course there's going to be some adhesions from the sleeve. Not too many, but I do want to underscore just how nice the robotic platform is when it's time to take down adhesions. So you can get yourself the perfect traction counter traction. You can use energy. You can use nice sharp scissors every time. It's not moving. You don't have to have somebody adjust the camera. And it's just a really nice way to be able to to get through the scar tissue. Now, when we do revisions for gastrojejunostomies or revisional hiatal hernia repairs, sometimes when you have that left lobe of the liver just plastered to your rulum in the pouch, it's really nice to have this technique, and it's really nice to be able to see the planes so beautifully. So again, you can see we can do that. Something that laparoscopically can be quite a challenge sometimes and makes for a bad day can actually be kind of fun robotically. So there I took down the adhesions that are necessary to take down after the previous sleeve in the lap chole, and this allows me to free up the duodenum there and make sure that I have plenty um, of room to get my 1.5 to 2 centimeters. Now, that portion, I'm happy to show you guys another time how to do it, the DI, the hand sewn DI, and how I do it. And there's a video out there in the Fellows Project where I did that. But for this discussion, and there you can see your common bile duct. For this discussion today, we're gonna leave it at just the dissection. So you can see my duodenum there. You can see I've gotten the omentum off of it. And now we're gonna move to the right. And really, the only difference between doing it in one stage and doing it in um, as a conversion is going to be identifying where the staple line ends. And it's usually 4 to 6 centimeters from the pylorus. For me anymore, the primary anatomic point of reference is the incisura. I don't really look at the pylorus anymore, and it turns out to be in about the same place. I do like to use the tip up on the in the right hand because it does give you that nice ability to retract up without damaging the stomach. And you can see there the end of my staple line, about 4 to 6 centimeters from the pylorus. When we do a primary one single stage SADI or a DS, we like to do about a 60 French bougie, but usually I use a 40 French bougie and divide very loosely. So it's about the equivalent of a 60 French bougie. And it's important to remember that with these hypoabsorptive procedures, you're going to need more of a reservoir for um, for um, food intake to avoid nutritional deficiencies. So you might say, well, what if you've done a sleeve on someone with a bougie of 40? Typically, after a while, after several years, you're going to have some adaptation, and it's okay as long as you make sure you have a good 300 centimeter common channel. So you can see some scar tissue there to the right, omentum that's scarred to the staple line. And I do like to dissect the antrum posteriorly to at least get some pneumoperitoneum to the superior side of the duodenum. And I'm kind of a maximalist here, not rather than a minimalist. There are people who will do a tunnel by the duodenum and just transect right there without any dissection. I think that's okay if you're comfortable doing that. I really do like the idea of swinging the sleeve around and bringing it down so it has a really nice direct attachment to the ileum, and it's a really nice anastomosis that sits lower in the abdomen rather than way up by the portal triad. Sometimes, if it is way up by the portal triad, I've tried that, and it's extremely difficult to scope the patient if you do want to study the duodenum and your anastomosis. So there's Evan, Dr. Kowalski operating away. I'm trying to pretend I'm doing something. Sometimes I draw on the monitor just to make myself feel like I'm in the game. But he's kind of on his own there, and pretty soon here you're going to see the gastroduodenal artery. So, all right. So I'm gonna let this go and see if there's any questions up to
Some
this.
people it's friends, maybe spirituality, maybe something different. For me, it's family, and for you, it may be something different as well. But I just want you to.
Oh, I'm sorry. I don't think that was a question. I was trying
I
to
think
figure
that was very
out.
interesting, though, about
That
spirituality.
was very interesting. You know, we're talking, speaking of spirituality, here's my spiritual leader, bariatric spiritual leader, Dr. Stephanides. Dr.
Yeah, sure.
All dressed up. You had a deposition today, right? No, he's at Sages. I'm just
Yep.
kidding. So, in any event, this is very much like we would do if we were to do a single stage or a revision. And you guys can see there, you can easily see a nice gastroduodenal artery, a really nice, beautiful view of it as we're dividing there. You can see it, and it gives us about a centimeter and a half to 2 centimeters of duodenum before we transect. But for the purposes of this video, this is as far as I've taken it. So any questions on conversion of sleeve to SADI while we run the last few minutes of this video, and then I'll turn it over. I'll go to my type 1 distalization video, and then I'll turn it over to Dr. Stephanides.
Dr. Dan, I had a
Yeah.
question. Now, do you routinely check them for hiatal hernias, and would you fix that?
That's a fantastic question. So, we do routinely check them. I do an endoscopy on everybody, mainly to evaluate the duodenal bulb and to make sure it's healthy, and we're not dealing with some kind of ulcer where you're going to have a stapling across an ulcer would be a problem, obviously, H. pylori, all those things. But I treat hiatal hernias in revisions or conversions of sleeve to SADI as a hernia outside the surgical field. And that's just me. It doesn't mean it's the right thing to do. Doesn't mean it's wrong to do it all at once. But I do have a hard time when I keep my ports very low, reaching way up in the hiatus. And I feel that whether it's one or the other, for one of the two, I'm going to have suboptimal ports. So I tell them, hey, we're going to get you a SADI. You're going to lose more weight. We're going to come back to fight another day. No different than if somebody had an inguinal hernia, right? Now, if it's a severely symptomatic hernia, that's a different story. There are exceptions. But in this situation, I would just say we'll come back and fight another day. One of these operations can be an hour and a half, maybe even more. Adding a difficult hiatal hernia to that doesn't need to be done because it's not within the surgical field could take a very high risk patient to a 2-3 hour surgery. And I just don't see the need to do that if we don't have to. Okay. If the patient demands it, if it's very symptomatic, yes, I will do it. But typically, I don't like to. So thank you for bringing that point up. Faze, what do you do? And Demetrius, what do you do?
You want to go first? I do the same thing. I'm always kind of, you want more information before you take them for conversion. So get all the information, upper GI, endoscopy. And again, now, if it is like really big, then I'm obliged to fix it at the same time. But if not, I'm just not looking at it.
Come back and fight another day. Plus,
Yeah,
I honestly
come
think you're
back.
giving the patient a better chance for a better chance for but good outcome if they've lost more weight.
100%.
Okay. So again, I'm a big fan of maximal dissection here and evaluation. And Demetrius, we did mention there are some people who like to create a channel and just fire that stapler right across the duodenum there. So Demetrius, I kind of want to get your input. Am I doing everything right?
Of course.
So
So again, I think what's important for the fellows to understand, there are some things that are matter of preference, right? And some things that work better for you, for me, for whoever's doing it. And that's the art of surgery, right? So you need to, in my opinion, you need to try different things and see what makes the most sense to you and what works best in your hands. Ideally during your training, because then you're more in a protected environment rather than later. But as you get more comfortable with surgery, you can definitely try it later too. I personally, I like the tunnel around the duodenum because I hate disrupting blood supply to any bowel that I have to interact with in general as a rule.
That's a great point, Demetrius. So if anybody does a gastric, there are people who will take down gastric bypasses, convert them to a sleeve in order to do a switch or a SADI. I'm not one of them. But if you ever do that, remember that some surgeons, including myself, take the descending branch to the left gastric. If you take the right gastric, which I do routinely, as you see here, and you have a sleeve gastrectomy where the left gastroepiploic is out, you basically have a gastric conduit that only has one vessel. So taking down the greater curve for the SADI is not an option in that situation. So that's something else to remember. But those there's very few people that routinely do those operations. So I think we're coming to the end of this video here, and I'm going
Dr.
to,
Dan, there was a question
yeah,
from one of our fellows. They said, "Do you use ICG?" And looks like you for on revisions.
yeah.
It looks like you.
So we have used ICG because I'm very aggressive about taking down the right gastric. But my my partner, Dr. Mellert, will tell you don't want to use ICG because you won't like what you're going to see. It gets purple sometimes. Dr. Shimke and my colleagues sometimes call it the blue odenum, jokingly, but we've never had strictures or problems with it. I've seen one stricture at the DI, and it was amenable with dilation. So I want to show you guys something that you don't see very often, a type 1 distalization. If you do these, I encourage you to please become familiar with what bowel limb lengths should be, what the variability is, and understand that a gastric pouch with 100 to 150 centimeters of rulum is the equivalent of about a sleeve gastrectomy with a sleeve conduit with a pylorus. So that means that after the rulum, you need at least 300 centimeters of small bowel. So I start by counting the rulum just to know, and I'm trying to do this super fast because it's painful. There's my jejunostomy. I identify the biliopancreatic limb and I count that without tape to make sure it's about 40 to 50. I identify the terminal ileum, sala treves. I have to go 20 times speed here because this is painful to watch me count 300 centimeters. But after counting 300 centimeters, what we do is we mark the bowel with a suture, right? So you know that your gastric bypass, 100 to 150 centimeter rulum plus 300 centimeter, gives you enough to not become leave the patient as a nutritional cripple. And then you count what you're going to add to the length of the BPL, okay? So we reach about 300 right here. This is the spot where I'm going to be anastomosing my rulum. I place a suture, and in this patient, I think we counted about 200 to 250 additional common channel. So essentially, by dividing the rulum and plugging it further down, this common channel becomes part of the biliopancreatic limb. So again, the ability of the robot to give you stability, traction, counter traction, take down some adhesions. In this case, there's some momentum that's stuck to the jejunostomy. We see that quite often. And once we've done that, we identified the spot. Remember, your mesenteries are not going to match anymore once you get the rulum further down. There's a mismatch in mesenteries, but as long as you understand that. And I make my little window there, slowly spreading, using the vessel sealer. I do divide a little bit more to make sure I have plenty of reach. I fire a stapler, ideally pretty close to the old jejunostomy. And what you see on the left there is my rulum. Okay. We divide that. And then we carefully bring the rulum down to the anterior aspect of the mesentery on the right side of that common channel, patient right where we have our previously marked spot. So all that bowel there is now becoming biliopancreatic limb, and we're lengthening that, shortening the common channel. Rulum stays the same. I enlarge the mesenteric division just a little bit, place them side by side. Sometimes if it doesn't sit as nicely as this one, I will run a barbed suture posteriorly to line them up. I often do that with ileocolostomies for right hemicolectomy also. And then a couple enterotomies, of course, right over a vessel. And same thing on the opposite side. And then we follow that with a 60 millimeter. You want to make a nice wide anastomosis. Make sure you get plenty of drainage of the rulum into the new common channel. And then once we have the side-to-side anastomosis done, we're going to be left with a defect that we close using barbed suture and running fashion, with great care not to obstruct the lumen of the common channel. And then we also close the mesentery. You can see if you put your ports really low, I can't overemphasize how important it is that you place your ports really, really low. I certainly would not do a hiatal hernia repair with the type 1 distalization, because I put my ports almost where you would have if there's an incision for a abdominoplasty, that low. And I think I took out the closing of this just for the interest of time. But very low placement allows you to be able to find your ileocecal valve and allows you to be able to count all the limbs and to comfortably be able to perform your jejunostomy. Again, more serosa, less mucosa to try to imbricate it. And I think that's it. So with that, I'm gonna stop the videos here. We're at the end, and I'm gonna open it up for any questions before we move on to Dr. Stefanides' portion.
So, Dr. Dan, there was a question in the chat. It's just generally asking what our preferences is. If someone has had a sleeve and they either had weight regain or incomplete or, ability to lose weight, and they don't have GERD, what would you prefer, SADI or a bypass?
Oh, in my hands, it's always going to be a SADI. I try very hard not to do bypasses except in patients with Barrett's esophagus or severe GERD. And the reason for that is because at one point, I've done a lot of gastric bypass over the years. At one point, a quarter of my practice was taking care of problems related to the gastric bypass. And the benefit of SADI is that theoretically, a lot of those risks are mitigated. Dumping syndrome, internal hernias, marginal ulcers, strictures, intussusceptions. You can still get some of those, but much, much more rare. And the weight loss is better and the metabolic impact is better. So to me, it's a no-brainer. I don't understand, jokingly, I'm going to say ruin why, WHY, right? So, but it still does have a role in patients with Barrett's esophagus, severe GERD, or if for some reason you cannot count the terminal ileum. So, a better sleeve, the option for a SADI, have kind of replaced the gastric bypass in my practice. But there's a lot of surgeons who who cite their familiarity with the gastric bypass as a reason why they continue doing it. That's absolutely fine as long as the results are good.
Before I come to Dr. Stephanides, I just needed one more question. What's your conversion algorithm? So is it dependent on BMI and diabetes? Like, would you go for SADI, 300 centimeters, 275, or are we doing DS for high BMIs with 150, 150?
Who are you
Demetrius, I
asking?
think that's for you.
That's for me?
Oh,
Okay.
actually, it was for both of you.
Okay.
So my algorithm, Faiz, is that is similar to what Dr. Dan mentioned. If reflux is the main reason that the operation is done for, which is not unusual, then usually it's going to be a bypass choice. If weight is the main reason the procedure is done, then it's going to be a switch.
A switch.
I don't do SADIs mainly because they're not covered by insurance in our area. It's the same procedure, just with an extra step to doing the switch. So the gray zone is when you have patients with both, and then I'm doing the best I can to really have a good discussion with the patient and reach a common decision making, what's more important to them. And I've had patients with not with reflux symptoms that are not mild, let's say, but they really want to maximize weight loss and they choose to have this understanding that they won't fix the reflux. It may improve it some, right? Because you divert the bile away. But and especially if they have a hiatal hernia, which is not unusual in that scenario. Most of the time, I think that I've operated on patients with sleeves, converting them to something else. There's, I would say, in my experience, 80-90% is a hiatal hernia involved. We do have the discussion that will help some the reflux, but it's unlikely to make it go away completely. And if they're willing to take that risk, etc., meaning not fully addressing the reflux, then I will do a switch in that situation.
And do you alter your limb lengths for the switch depending on patient's BMI? This is for revisional cases. If, say, someone's BMI is 50 after a sleeve, as opposed to, say, if their BMI is 40, is there a difference in your algorithm?
So, if I may, Demetrius, because I think that's a really important point. So, with regards to the SADI, I don't do a lot of DS. I prefer the SADI. 300, we know that when they started doing it in Spain in 2010-ish, 250 was too short. A lot of people had diarrhea, loose bowel movements, nutritional complications. So we upped it to 300. It's kind of the conventional wisdom. But I always tell the fellows and the residents, if you have a, young gal, she's young, but with severe obesity, she's small of stature, but severe obesity. You know what? We're gonna go 270. We're gonna get you a little bit extra. We're fighting severe refractory obesity. If you have a guy who's 6'5", played professional football, gained weight, that guy's gonna need more protein. So I may go 320, 330, 350 on that patient.
Interesting.
So you do have to have the ability to kind of, dial it in a little bit to what you need. So that's an incredibly important point. Demetrius?
So I will agree with this. This applies also to the distal bypass that Dr. Dan presented. I have to tell you that I have been doing this for a while. It's an imperfect science, and my advice to the fellows would be don't start with this type of procedures once you're out there, because their outcomes are not as predictable as you may think. For example, distal bypasses, I almost never go more than 150 common channel. Okay. And I still have a few patients who don't lose much weight. So keep that in mind. I have others who lose a lot. Um, Most are doing fine with nutritional issues as long as they do what they're supposed to do. The time they get in trouble is when they stop doing the thing, and that's human behavior. So keep that in mind. But the point being is that our data, we've done a distal bypass with about 50 patients. Our data suggests that the way we do this, the weight loss approach is that of primary bypass, but that's the average. If you individual, there will be a less than 10% of patients who will lose very little amount, and they'll be very unhappy, and there'll be some who lose a lot of weight. So I think we don't fully understand the reasons. I think the considerations Dr. Dan provided are important, but there's many, many more things we need to learn about this. It's a little more complex than just measure and cut and go, as we have been doing. We're trying to do some research in this area. We have done some looking at the relationship of the common channel to the total length. So and that's what I do take into consideration, because we have found that when the total alimentary limb is more than or less than 50% of the total, those patients lose more than if it's more than 50%. They will lose less weight. So that I do measure the whole length, and then I try to adjust my limb to some degree to that. With the switches, I always go to 100, maybe a little more, but not much more. Because the other reality is a lot of the patients we see are really big too. So
you said 100 common channel for the switch?
Yeah.
And then the root limb
150.
150. Awesome.
So
And
I'll say I couldn't agree more with Dr. Stefanidis on that point. It's a lot more complex, and I tend to be incredibly conservative. So if someone doesn't, I'm not going to do a whole distalization for an extra 50 centimeters, but I'm not going to leave you with more than about 350 minimum to 400. Anything less than that, you run the risk of getting marginal benefits, but potentially giving the patient an operation that's going to make them nutritionally compromised. So it's a bit more complex than just measuring. I couldn't agree with that more. And I will say that if we had measured the common channel of every operation that's been done since bypass came about 50 years ago, we would know a heck of a lot more than we do today. And maybe that's something that's a lesson to be learned for the future. But same with OAGB. OAGB has you always have to make sure you count your common channel to make sure you're not leaving too short of a common channel, because you can get into trouble with that.
Great. One thing is, I've started becoming a little bit more aggressive with these things. I think what Dr. Stefanidis said is, initially when you're starting off your career, you want to establish yourself as a safe surgeon, go safe, go do what's conservative. But now I feel like I'm pushing the boundaries a little bit more, just because you can have the discussion with the patient. So if I be a little aggressive, I might be able to get them the weight loss and then get the second or third surgery covered, because now it's malnutrition, or I don't know if that's a right way of thinking or not, but I feel like these patients, when it's their second surgery, that's almost like that's going to be kind of their last chance. So, but good to know.
I have not had to go back and lengthen the channel yet in the 50 patients I've done. But I have gone back once and made it shorter in someone who didn't lose much weight.
That is awesome.
So just now, that doesn't mean it's not gonna happen. Okay, so it will happen because it is more on the aggressive side. I understand that. And I have had patients who do have deficiencies in the long run, but one of them is alcoholic and doesn't take anything. And that's really hard to fix. And the other one also has not been taking her vitamins, and we fixed that. But I mean, that's the challenge, and you should be aware, and I've seen this, unfortunately, in my experience with switches, etc., so that some people will get in trouble, will get vitamin deficiencies that will lead to other problems. It's rare, but it does happen, so you please select them carefully.
Awesome.
Because if they don't take what you ask them to, no matter if they have a switch, they have a SADI, they have, even with bypass, it can happen. that's so much less malabsorptive, they can get into bad trouble.
Awesome. With that, Dr. Safaris, I think we would like you to make your presentation now.
Absolutely, and thank you. So just so I don't teach the fellows the wrong way of pronouncing my name, Stefanidis. Sorry about this.
Sorry.
All right, it's okay. So just a few things. I don't know if Adrian, you went through some of the
I did not.
okay, so some general comments besides going. I'll go over some procedures, and actually will be complementary to the ones that you saw Dr. Dan present. But why is it important? Because obviously there's a lot of procedures we do along those lines. They're harder to learn, and the outcomes are generally inferior, but also less predictable, as we just discussed. You probably have seen this. It just indicates that the number of revisions are going up. Now, this is a few years back. I don't think it's changed too much. Obviously, we're talking about robotics. You can find articles online that argue both that robotics helps or it hurts. And that's what these slides are supposed to show here. One of the more recent papers that I have included here, we haven't published that yet, but we're finding actually that robotic outcomes, when you look at the endoscopy data, continue improving. And interesting enough, the laparoscopic continue improving too, but they're getting very close as of 2022. So the point being, the technique really is defined by the surgeon that's using it. So if this technique makes you have your best outcomes, you should consider doing it. And if not, use the technique that does. Anyway, so this is kind of my assessment of the available evidence that it does capture definitely learning curve. Robotic experience less pronounced as laparoscopic. It is used by less experienced surgeons. That probably plays a role. But as we gain more experience and expertise, I think the outcomes, as I mentioned to you, as of the most recent study we've done, become very similar. And perhaps will improve as we gain further experience. So why I like using robots for my revisions? Because I can see better. And I put that can be confusing at first because if you are used to seeing everything laparoscopically and you transition to robotics, there's a new learning curve because things look different. They're more magnified, and you don't expect it, but it is. Now, if you've experienced both in your training, you may never go through this, but I kind of learned one on my own after I had perfected my laparoscopy, let's say. I can dissect better. I can do more things. I don't feel as limited as with a laparoscope. And I do feel I have more control of the operation. I don't have I usually work with trainees, but you always essentially work with someone who's less experienced. And in some of these cases, you really need another experienced surgeon. And we don't often have that luxury unless you're in a private setting and you operate 2 surgeons at a time. So what the robot may allow you to do because of the third arm, you have yourself helping yourself essentially. So, and that can be useful for the very challenging cases. And I also feel that I can teach better. The dual console provides a great way to do this. And if you add all of this, doing it with less effort, mental effort, as well as physical effort and less discomfort at the end, because some of this, when I was doing them years ago, laparoscopically, I still do them occasionally. I feel like a train ran over me at the end, and robotically, I don't. So the revisional procedures can be for weight recurrence, right, or for complications. And there's multiple, as I'm listing here. I know I don't have as much time, so I'll jump over some of this. But general considerations, going back to the comment I made about your assistant, right? So if you work with a trainee and they're on the dual console, that assumes that someone at the bedside is helping you. Don't assume they know what they're doing unless they're really the team you're always working with and you know they're good. And if they're not as familiar, prepare them. I try to minimize instrument exchanges because that increases the challenge for the bedside assistants, especially if they're not very familiar, and increases your frustration because it goes wrong every second time they do something. I always use an assistant port. I was laughing the other day. I went to the OR to help one of my younger colleagues, and she was doing a revisional procedure, and I'm like, "Where's the assistant port?" And she doesn't use, because I guess it makes us feel better when we use fewer ports. But these cases are not the ones you want to experiment without having assistants. That would be my advice to you. It makes things so much easier. You can get whatever needle you like. You can plan all you want with the needles ahead of the case. I know some people do this. You will always be wrong. At least that's been my experience. You'll always need something extra, and then you have to exchange again at the bedside. It's not worth the frustration in my experience. You can use that also for additional retraction. If you have a capable assistant that can come help you, because sometimes you need more than one hand. I use liberally sponges because I use them both to clean my field, but also to retract for multiple reasons. I find them extremely useful. And having a port that allows you to put it in and out can be very helpful. Some of these procedures can be bloodier than an average bypass that you do without any blood loss. And key, this is true for any type of surgery, but extremely important for revision surgery. You have to really learn how to use your third arm. If you don't know how to use your third arm, you ignore your third arm. Most trainees ignore their second arm, which is part of the learning curve. But you now learning also how to use the third arm. If you get good at this, that will help you greatly doing these cases. Always use endoscopy. If you're not comfortable, learn, because in my experience, it's key to doing good revisional surgery. I've been in numerous situations where I've relied on the endoscopy report that a gastroenterologist did, and I find something very different when I do the procedure, especially when it involves foregut. So I've learned to rely on my assessment because we have a different understanding. We see things on both sides if you do endoscopy as well, and then you can translate it better as to what to expect when you do the procedure. And the gastroenterologist cannot do this for you. Be mindful of procedure cost. I think that's always important. And perhaps the most important advice for me, when the going gets tough, change the going. So what that means is that every time you do revision surgery, especially when you encounter a really hard dissection, if you persist, you increase the chance of getting in trouble. So what I typically will do when I see that it's really hairy, I'll switch. I'll go to a different area where it's easier. And then when that gets really hairy, I'm going to go to a different area that's easier. Eventually, the really hard areas become a little easier when you follow that approach. Sometimes that may not be the case, but generally, you should exhaust any opportunity to approach the easiest aspect before you get to the really tough one, because that will save you some trouble oftentimes. What instruments I use, this is also some cost here, but generally, for primary cases, I tend to like the SynchroSeal. I know that's a point of making fun of me among this group, but I find it a lot better than the vessel sealer. The only benefit of the vessel sealer is that it cuts. But if you use the SynchroSeal and you get familiar with it, you can cut with it, and it's so much better for dissection because its tip is so much finer, closer to the harmonic, which I also love for dissection, and that's what I prefer. Why I prefer. You can also use it as a driver. It has multiple functions. But when I use it for revisional surgery, I use monopolar scissors. Yes, you lose the bipolar activity. That's why I replaced the Progress with a fenestrate bipolar. But for really challenging revisional cases, you cannot use an energy device for dissection because the planes are all stuck. You need really a scissor. And in those cases, I actually transition. If I'm converting to a bypass, this is how I position my trocars. I put the 12 port for stapling in the location shown in the picture. I know many surgeons put it the most lateral aspect of the patient on the right side. I don't like having my stapler on the most lateral aspect. I like to have my stapler between two arms that can assist it. That's the reason I put it there. I never have trouble getting to do what I want with that stapler when I position it there, meaning from a rich perspective. So that's the main reason. Whatever works for you is fine. This is what I put and what the order I put them in. But generally, I try to not exchange the lateral ports. Those instruments stay the same. And only the camera moves when there's time to staple. And then I have it here. So because I'm right-handed and I like to have two right hands instead of two left hands. And that's the only reason for the exchange. For switches, actually, I don't have to change. I only change one port position because it allows me to work with two hands for most of it and keep the camera stay stable. Dr. Dan referred to this. When you do a conversion to distal bypass, you have to move down your ports. If you don't, you're not going to be able to do the procedure, or at least do it well enough. So I do go as low as possible because for the distal bypass, you mainly work at the JJ and you bring it even lower, right? So and you need to be closer to that area or farther away, I should say, from that area. And that's when you need to move down your ports. For switch, this is my port placement. Now the 12 moves to the left of the patient, similar location, the medial port, not the very lateral. And so again, I can have two hands assisting that stapler from either side of it. And this is what I was saying. The camera, in this case, all 8 trocars don't change throughout the case. Only the 12 where I use a dissecting instrument, the stapler, and the suture cut. The one extra thing I do want to do when I have to do a sleeve at the time of the procedure, with keeping, in order not to use a 12 on the other side, I do move it a little more south to be able to take the first firing on the stomach, because otherwise, if you keep it up, it may be too close. It may be a struggle taking the first firing to divide the stomach. If you move it a little down, it allows you to do this, and it works for any type of the stapling that you need to do. So in the case for sleeve revision, obviously weight recurrence, we haven't published this information, but on a recent literature review we did, the number of patients who gain weight after a sleeve in the literature is around 40%. It's twice that of a bypass. So in the literature, the weight recurrence after bypass is about 20%. With a sleeve, the reported rate is about 40% if you aggregate the data. So we will see more of these. Medication may be an option, but for some of them, it won't work. So obviously, inadequate weight loss is another aspect, or we talked about already the reflux situation and some of the other complications that can go along with a sleeve and how you will deal with them. So define the anatomy. This is kind of my approach. Use the endoscope to define if you need to, especially if there's an area of stricture that you want to know exactly where it is. Fix the hernia. This is most of the time present, as I mentioned earlier. Typically divide the stomach about the second vascular bundle and proceed with the rest. This is a sleeve revision. Now, again, the challenge can be that there's a lot of scar typically, right, that's stuck to the staple line of the sleeve.
And at the end of the day, that patient's care is what matters most to everyone in that room.
Yes. That was not part of the video, I think. So anyway, so there is a lot of dissection that needs to be done here. I'll move it along. Will it play if I move it along? Okay, I'll go to the next slide. No, now it doesn't allow me to advance it. All right, so this addressed essentially a SADI versus a switch versus one or the other versus Roux and wide bypass. And I think Dr. Dan referred to this already, that if you look at the literature, clearly the weight loss is more after the switch procedures or the SADI versus the bypass. And that's important to know. And it's important, and that's one of the reasons you need to have it in your armamentarium, because when you have discussions with patients, if you only know how to do a bypass, you will only offer them a bypass, and I'm not sure you're doing them the best service if it's not for reflux. You saw the video about the distal bypass, similar indications. There's two versions, at least the way I approach this, so it depends, and they depend on how long the roux limb is. So if I first measure the roux. If the roux is 150, then it's a one-step procedure. So I divide the roux before the anastomosis, the JJ anastomosis, and bring it and plug it into the common channel that I want to create. As I mentioned, I usually do it about 150. Dr. Dan does it a little longer. However, if the roux is short, then typically I will do two anastomoses. So I'll make the roux longer. If it's, let's say, 75 centimeters, I'll make it 150 and then plug it distally to the same area. So in essence, I try to do about a 300 total alimentary limb in this situation, with some variability, because I also, as I mentioned, take into consideration the total length of the bowel, and want to make sure that I bypass more than 50% just based on our previous experience with seeing that they lose more weight. This is a distal bypass, but you already saw. I measure it with the tip up, which the length of the tip up is 5 centimeters, right, for the metal part. And you already saw this. Maybe it's good to have another view of this. So you have to obviously take down the mesenteric defect to be able to divide. Depending on what you decide you have to do, right? Depending on the length of the roux, you will either divide the roux proximal to the JJ if it is 150, or you'll divide the BP off, then lengthen your roux, and then reconnect after you create a new roux, connect that distally and reconnect the BP. So here we are dividing, as was shown, the BP. Sometimes you may create areas where there is ischemia potentially, because you cannot always see exactly where the previous staple line is. So that's why we're just doing there, implicating that area. It probably will do fine, but we don't like to take any risks. So now we've created a new 150 roux, and we reconnect the old BP to the new distal aspect of the roux. It's confusing, I know, and I'm sorry about this. And then again, imbricating some of the staple lines, and we'll go and create the distal anastomosis next. This is closing the mesenteric defect. I have to tell you that the defect closure is fairly tricky with distal bypasses. Not if you have to do a JJ again, more of the distal anastomosis. And the key, in my opinion, is you need to make sure you really visualize in the way you run the bowel to make sure nothing goes through the defect, because it's very easy to create anastomosis with bowel going through the defect. In other words, create an internal hernia as you're doing it. So you want to make sure there's nothing going through, and that's my primary concern with this procedure. And then, of course, closing that defect, which can also be a little bit challenging because it's a lot bigger typically. But I would not leave that defect open in any by any means. And that's the defect I was referring to in this situation. We already have closed some of this up here, and we're closing it now in its lower aspect. Okay, I'll go to the next slide. I referred to this earlier in our discussion. This is from our earlier experience. Now our experience is a lot bigger, but you see that the 2 years, the weight loss approached the one of the primary bypasses. So another thing we still do see, because a number of them were done in the past, are the vertical banded gastroplasties. And the indications for revision of them are similar. In this situation, you may also run in patients who have either a severe stomach stricture from the silastic ring or mesh sometimes that people use, and they may require reversal of their VBG. So in general, the concept here, what I try to do is remove the staple line with including the band if possible, mainly in order to avoid any blind pouches that can create problems, especially because it's not as easy to tell where those staple lines are. So these are the steps. It helps a lot. Endoscopy, again, can be a great guide to figure out where the staple line is. Generally use thicker loads because your staplers will misfire otherwise. The good thing about the robot is the robot won't let you do it, but nevertheless, keep that in mind if you don't want to waste too many staple loads. And I try to go medial to the staple line, and then, as I said, resect the lateral aspect too. I'll finish here because I know we're coming to the end of our time, but this is kind of what it looks like. This is a silastic ring. Usually there's going to be a suture that's keeping it together. In this situation, I'm using the synchrosil and not a scissor, but it's obviously easy to cut the silastic ring with a scissor.
Demetrius, the VBG is something that we used to see more often 10, 15 years ago, kind of stopped seeing them, and now I've got a couple that in the pipeline, but certainly something that you want to be familiar with as a bariatric surgeon, right?
I still see them routinely. I don't know where they're all coming from, but
I'm sending them all to Indiana.
I still see a few of them. I don't know, maybe half a dozen every 6 months or so, probably. But here, see, it's really hard to identify the staple line, especially because a lot of them will have gastrogastric fistulae where the staple line is broken up. I do make it a point to find the staple line, because if you don't look for that, what you end up doing is stapling over multiple folded stomach on it, because the stomach, what it does, it folds along the staple line, the old staple line. And you won't know where exactly it is. You can't really tell most of the time, unless you do get into this dissection, trying to figure it out. Because my goal is to thin the stomach enough that I can staple across it safely, if that makes sense.
I think that's really important, right? Like otherwise you'll have a blind pouch, and then that can cause necrosis and then maybe a leak or something. I actually haven't seen any of these in York, Pennsylvania yet.
So a lot of times it depends on whether there was somebody in your region 40 years ago doing them.
Right.
So here in
probably,
Canton, there was a guy.
Yeah, I guess that's probably part of it, right? So similar to when I was in North Carolina, we were seeing a lot of one anastomosis bypasses because Rattlers was there, and then we were addressing them.
At this point, do you have an endoscopy to see where you're
Yes,
going?
Absolutely. Especially because sometimes the pouch can be very narrow.
Yeah.
There's the endoscope.
Ah, I see. Okay.
So, and you really want to make sure you don't narrow this too much either, also, right? So you want to be on the side of the where you don't leave a blind pouch, but at the same time, you don't want to make it too narrow either.
Right.
Now, if you can position the stapler perfectly where the previous staple line is, you may not have to resect it, but it's not unusual that I do resect it because it's not always easy to tell.
Right.
So anyway, I'm not gonna go over this. I had a reversal here too, but
Demetrius, do you resect the fundus? If you're gonna resect the mesh and the other line, do you usually resect the actual fundus, or do you leave that in there?
I don't always resect the fundus. No, I may, depending on what's happening, but a lot of the time, as you know, that fundus. I mean, I resect the fundus if it's a fundoplication I'm taking down,
Okay.
because then it's beat up, and oftentimes there are concerns about perfusion or blood supply because the soric acid have been taken. But in this case, typically that's not the case. I don't typically remove the fundus. Do you?
I try not to, but a lot of times when I do have to take not a celastic band, but a Marlix mesh, for example, you just end up taking enough that you don't feel right leaving that fundus behind there. It's usually
Yeah.
well perfused, but
Yeah, if you have any concern, I don't think there's any downside. Just usually these procedures are really long and painful, and I don't want to add another thing that I have to do that if I don't think it's absolutely necessary. But if it is, absolutely. So take-home points to finish up. Revision surgery is tricky, and you better be well prepared for the unexpected because that's what happens every single time. And have an ace up your sleeve, as you say, as I'm saying here, which I find to be the robot. You can accomplish the procedure very safely, but generally the risks are higher than after primary surgery. And as I mentioned earlier, do not start your practice with revisions. Give it time until you feel really comfortable before you engage. Perfect your robotic skill on primary procedures before you try revisions. So this is it, and I hope, I'm sorry I went over some, but I hope this was useful.
That was
no,
very
that's great.
good.
And the more things you do, the more can go wrong, right, Demetrius? I learned that quote from you. So
Yeah, I mean, what I learned in my training, because when I was trying to decide what specialty I want to go into, right? So I had so much fun in transplant, and then I realized the more fun the surgery is, the more problems patients get afterwards. So of course, perhaps an exception is MIS because we do so many complex things, but yet patients are doing well. But there's still also some limits there too.
Totally. I don't see any more questions in the chat. I actually had one question regarding weight gain in bypass patients. Just if you could give us a quick rundown of what your algorithm is. When do you talk about, first thing, do you convert them to SADI procedures? I know.
So thank you, Faiz. Great question. So the question is, patients after bypass with weight recurrence, what do you do for them? So we do have an algorithm. The algorithm is we engage them in the back contract program. I'm sure everybody does this. We know that's not going to work much, but it's an important component. Then I scope them, right? So my decision point there is there gastrogastric fistula? Not common, but some people have it. And if they do have a big one, if you just take the gastrogastric fistula down, they'll lose the weight back and they'll be fine. And also assess the pouch size and anastomosis size. I'm not a big believer, honestly, on making pouches smaller and anastomosis smaller. They do provide some benefit. I don't think it's long-term benefit. In my experience, I've tried this early in my career. It doesn't work as well. There's multiple different people arguing for whatever. That's fine. I've had my own experience. I'm not bought into this. I've done this. I wasn't happy. I decided to move more towards the distalization just because it does work for the majority. And even then, as I said earlier, not everybody, okay? Obesity can be a very hard thing to address, as we are learning. So the endoscopy is another aspect. Maybe select patients you could offer like narrowing of the anastomosis. I deep inside believe you're torturing patients because you're making them, give them dysphagia, and that's how they lose weight. They cannot really eat if you make it too narrow, right? And maybe they're happy. But nevertheless, then we put them through the process. I have the team evaluate. I check vitamin levels on everybody because most of them won't have had it done, in my experience. And if they have deficiencies, now I'm very hesitant to offer anything until all these are corrected. And if they're not corrected, I'm not doing anything, right? Because I'm going to make it even more problematic from that perspective if I do a distalization. So then I do have a conversation with them about if we reach the point of surgery and everything else seems to check, right? And the patient seems to be very much with it. They understand. I brainwash them. What do I mean by that? I tell them, every time I see them, I tell them, what's the most important thing you need to remember after this procedure we're talking about? And eventually they all learn, I have to take all my vitamins. If they don't say this, we keep having that conversation, okay? Because that's really the most important. Because the procedure itself is not necessarily as risky, but what is the biggest risk is they stop taking the vitamins down the road. So then I have the discussion about going from a bypass to a distal bypass versus to a switch or SADI. Now, the reality is that I am biased, and I'm biased from the perspective that I don't know that we have data that suggests that one is better than the other. We need to get that data. And second, based also on my experience, but I do know that if I'm going to go from a bypass to a switch, it's going to be a lot bigger surgery. And I also have learned in my experience, bigger surgery means bigger problems in some percentage of patients. So that's how I present to the patient. We can do this, or we can do that, but this is a lot simpler, less complicated, and in my experience, at least, it provides good weight loss for most people, but I cannot promise you're going to lose as much weight. This is the data. This is my experience. I have had a couple of patients who haven't lost much weight, but I've had others who lost a ton. And I try to give them that perspective. Now, occasionally I will have some patients who will say, no, I just want to have a switch. In those cases, I will do the switch as long as they understand the increased risk. Now, I wish we could do some study that kind of compares the two, right, in a more scientific way, so we can really see what are the pluses and minuses. But generally, and Dan referred to this, Adrian referred to this during his presentation. I tend to believe that if patients have been able to regain a lot of weight with the bypass, and the pouch is not huge, right, or whatever pouch it is, they know how to eat to keep that weight. So I've come to realize that, because people say don't do both, right? Don't make the pouch smaller and this. And I have tried to avoid doing this. I don't think maybe I've done this once with someone who has a really big pouch. But generally, I'm not that concerned that they will have too much malabsorption, because especially if their BMI is high. So one consideration to Adrian's point earlier, if the BMI is extremely high, I'll go shorter on the limb.
Okay.
So because they need more help. Now, again, it's not about the measurement, because we still, there's many more things we need to learn about this, but that's usually how I approach this.
Thank you.
Yeah, Faze, if I can just also add to that, these procedures aren't for everybody. And the type 1 distalization is an easier way to get somebody the type of hypoabsorption and metabolic impact that's kind of similar to a switch procedure. So that's why we do it, because you don't have to take down the roux and make a sleeve out of it. and all those things, but the traction hasn't been um, what you'd expect it would be because the results are so variable and the dangers are so real. So in my practice, I can tell you, BMI under 40 after a sleeve, we high five each other. Over 40, I start considering medications or another procedure. But my nurse practitioner, when she walks out of the room, she looks at me and she gives me a look once in a while that says, "Don't you dare, don't you dare bring up SADI." And she doesn't have to say a word. And that's it right there. Because she knows if the patient's been showing up to the office, she knows if they're taking their vitamins, she knows what kind of questions. I mean, you really need somebody who gets the fact that if you don't take your vitamins, it gets real. And that's probably the first thing we should have started with when we talked about revisions and conversions is patient selection. But we do try to keep this program technical because it's about robotics. So, but please remember that it gets real. So increased bowel movements and vitamins, and it has to be your new religion. Speaking of the brainwashing that Demetrius talks about, I always, before surgery, when we go back there, what do you have to do? Take your vitamins. So be very selective, guys, because you do want to get the reputation for doing the right things for the right people. And even so, you're still going to have some bumps in the road.
Last chance. Ask your questions. Unmute yourself. Okay, going once, twice. And with that, I think we had such a wonderful session. I learned a whole lot from you guys. So we'll see you next month.
We'll see you all in Atlanta.
I think we have
That's
a
right.
session for that.
Yes.
Do we have one right before
One
Atlanta?
before that,
Okay.
and then we see them in
All
Atlanta.
right, that's going to be awesome. It's going to be
Yeah.
fun. We'll have some food, have some drinks, and talk some more robotics. Okay, and I believe both of you guys will be there, right? Faze and
Right.
awesome. Okay, great.
We'll see you guys.
Looking forward to it. Okay, y'all have a great evening.
Great seeing everybody.
Bye.
Take care.
Bye-bye.